Good morning. This is a 45-year-old female who presented to us with neck pain with radiation to the back of the head and both upper limbs for the last 3 months. It was really aggravated. She also had mild imbalance on walking and occasional difficulty in performing fine movements of the hands, and her examination gait was normal, but the tandem walking was possible with great difficulty, and she had the typical wasting of small muscles of the hands and bilateral grip strength were weak. Sensation decreased over the left C6 term, which was patchy, and on the MRI you can see a typical CHIARI malformation type 1 with a large seedings in the cervical spine without any instability on flexion extension views. So this is the preoperative macroscopic picture of her exposure, and as you can see on the left hand side, which is the cranial part of the patient, you can see the occiput well exposed and the C1 arch on the right side exposed, and the marking is done for the area of resection over the C1 arch and subsequently over the occiput. Now, this is, I think, one of the critically important steps, because once you are into a higher magnification in the microscope, you tend to lose out the markings over which a resection has to be done. So once this marking is done, you're all ready for starting burring out of the occiput as well as the C1 arch subsequently. I use a 6mm cutting burr initially, and then I would go on to the diamond tip burr once I reach the deeper cortex. So this is the arch of the C1, which is being burred out, and to the inferior part of the screen you can see the left side of the patient, and the superior part will give you the right side of the patient. The left is cranial and the right is caudal. So the burring goes on till the trabecular bone is visible with the cutting burr, and once the trabecular bone is no more visible, once you're into the posterior or the deeper cortex, I'll switch over the burr from a cutting burr to a diamond tip burr, because that increases the safety. So this is the diamond tip burr which comes in once the deeper cortex is visible, and repeatedly moving to and fro, you can gently burr out the deeper cortex so that you are now into the soft tissue. Once you get a feeling of the soft tissue with the dissector or an Adson, you're all ready to take out the soft tissue, which is the main tethering structure, which actually constricts the neural structures, and the CSF flow gets completely haywire. So this is the final part of the C1 arch deeper aspect, which is being burred out. And as I've already reached the soft tissue on the cranial aspect, now I've reached the soft tissue on the caudal aspect that is underneath the C1 arch. And this microdissector tells me that I have reached the end point of burring, and I'm all ready to take out into a small 1mm kerrison punch, which should be gently inserted into soft tissue, and you should not try to put a lot of traction into the soft tissue while trying to resect out these bands, because that will aid in the neural structures getting traction. It's much easier and safer to use a 15mm or a 11mm 11 number scalpel blade to gently peel out the soft tissue from the dura. As I'm doing now, you can see I'm putting a little bit of traction with the suction tip on the left hand, and the right hand I'm using a micro scissor to gently dissect out these soft tissue, which is the main constricting band underneath the C1 arch. You can now see the dura over underneath the C1 arch, and a part of your job is done. And in the left side, you have completed the resection, and on the right side, a little bit of the bone and soft tissue is left, which I'm now trying to insert my kerrison punch. This is a 1mm kerrison punch, which goes underneath the soft tissue, and gently again repeat the procedure which we did on the other side by not pulling too hard, and again making sure that the decompression is complete. So once this kerrison burr is put in, you must also check out whether there is a gush of bleeding or not, because there are occasionally a lot of venous plexus which bleeds horrendously, and it's nice practice actually to do a bipolarization cautery of each and every step because once the bleeding starts, it might be very difficult to control. So now you can see that the upper cervical dura is reasonably well seen, and if you carefully look at it, it's pulsating well. And this is the last part of the left side, which is decompressed, left side of the patient, by a final few bites of the kerison. And now the soft tissue over the dura underneath the C1 arch and the soft tissue underneath the occiput have been taken out, and the dura is exposed. Now the most difficult and most critical part of this surgery is to take out the intervening, that is the area of between the occiput and the C1. That means the foramen magnum proper. As you will see that once these final kerison punches are digging into the occiput, the main constricting band is delineated so well. Now this main constricting band, as you can see, the dura above and the dura below is visible. And now what I'm pulling across is the main constricting band, which is a soft tissue. And this has to be bipolarized and made sure that there is no bleeding. And bipolar cautery also shrinks the tissue so that it is easier to peel off, and I use the microdissector to free it out completely. You can see that there is a bulging dura above, under which the microdissector goes in and creates a space for your instrument to go in. The next instrument which you will carefully observe is a hook which goes underneath the shrunk soft tissue, and that is the main instrument which tries to peel it out. So I'm using a forceps now, and I'm just taking out the superficial layer of that soft tissue with a knife and a tooth forceps. This transverse band is the most important constricting band, which needs to be removed completely for a proper decompression. Now I'm using the hook which I was telling you just now. This hook goes into underneath the soft tissue, which is the main tethering band. And again, you use a knife. Usually it's number 15 blade, which cuts it sharply over the hook. And this technique is pretty safe because you cannot injure the underlying structures because you're cutting on the instrument itself. This small piece of tissue, which is now isolated on the right and the left, is now again made a sharp dissection, and this sharp dissection is through a knife, which is peeled out from the dura. And this taking this out is the main part of the surgery. And the completeness of decompression basically depends on how efficiently and how completely you cut off and remove this transverse band. Make sure that you do not have a dural leak here, because a dural leak might be very difficult to tackle so far as wound healing is concerned. Now you can see that the neural structures are pulsating well, and it is not bleeding a lot, and a final few bites are being taken from the kerison, and we will soon be ready for taking out the closure. This is the entire neural structures which are pulsating well, and final few bipolar cautery steps are being taken so that there is no bleeding. This is under very high magnification under the microscope, and there is no further bleeding. As you can see, the foramen magnum is completely decompressed, and there is no further bleeding there, and a few pieces of surgicel is placed over the neural structures so that whatever microbleeding is there stops. A standard closure follows, and the patient is basically then extubated, turned over and extubated. The postoperative CT scan shows the arch of the atlas, which has got resected in the midline on both sides equally, and the part of the occiput which has got also resected out, and a nice space is created so that the posterior fossa is widened. Thank you very much.